Hello, everyone, and welcome to our module on intracranial bleeding. So there are 5 different types of intracranial bleeding that you need to know for your Step 1 exam. They're all listed here on this slide. This last one is a special one that really only happens in premature babies. All 5 of these different types of bleeds are depicted in this image here, and we'll go through them one at a time in the rest of this video. So before we can talk about specific types of intracranial bleeding, we have to review the meninges, which are 3 membranes that cover the brain inside the skull. And the reason the meninges are important to intracranial bleeding is because the different types of bleeds occur at different spots relative to the 3 meningeal layers. So let's take a look at this image on the slide here. This is the skull depicted right here, and then beneath the skull we have the 3 layers of the meninges, those 3 membranes that cover brain tissue. The first layer of the meninges just beneath the skull is called the dura mater. And so one of the bleeds we're going to talk about is an epidural hematoma that occurs above the dura mater. And then we'll also talk about a subdural hematoma, which occurs below the dura mater. Then beneath the dura mater, we have the arachnoid layer and finally the pia mater. And so subarachnoid hemorrhages are called subarachnoid because they occur beneath the arachnoid layer. So keep these 3 layers in mind. We'll talk about them a lot in the next few slides as we talk about the different types of bleeds. Okay, our first form of intracranial bleeding that we'll discuss is called an epidural hematoma. This occurs when there's rupture of the middle meningeal artery, which is a blood vessel that is a branch of the maxillary artery, and the middle meningeal artery runs just beneath the skull above the dura mater. So if you look at this drawing on the slide here, this depicts the external carotid artery, which gives off the maxillary artery as a branch, and then one of the branches of the maxillary artery is the middle meningeal artery, and it's going to run just under the skull above the dura mater. And in that space, it's vulnerable to rupture, especially if there's trauma and a skull fracture, because it's very near the skull bone. So when there's bleeding from the middle meningeal artery, that's going to lead to the accumulation of blood between the skull and the dura mater. And that's why knowing the layers of the meninges, like we talked about in the last slide, is important to understanding these intracranial bleeds. Usually the cause of an epidural hematoma is trauma, especially if there's fracture of the temporal bone, and we'll talk more about this in just a second. So when a patient comes into the emergency room with a head trauma, one of the first studies that's often done is a CT scan. And what it will show in cases of an epidural hematoma is bleeding that takes on a biconvex shape inside the skull. Biconvex means it bulges outward on both sides like a lens. In fact, sometimes the bleeding is described as having a lentiform appearance, and this literally means lens-shaped. And so if you look at the CT scan on the slide, it shows epidural bleeding. That's what's right here. And what's happening is the dura mater is attached to the skull at the edges here. It's remaining attached at the edges, but it's been separated from the skull by the bleeding in the middle. And so what you get is blood that pushes out, but it's pinned at the sides. So you get curving on both sides, and that's why it's called biconvex. You should also note that this is the midline of the brain tissue inside the skull, and sometimes that can get shifted to the side by the epidural hematoma. This is called a midline shift, and this is a sign of increased intracranial pressure. And then the usual cause of death when patients have a large epidural hematoma is that they develop an uncal herniation, which I talk about in the video on herniation syndromes. But in an uncal herniation, part of the temporal lobe herniates and compresses the brainstem. This will cause the pupil on the side where there's a herniation to become dilated. This is described as a blown pupil. So someone who has head trauma and has evidence of epidural bleeding like this and then develops a dilated pupil on one side, that is an ominous finding. That means that they are likely to die very soon from uncal herniation. So epidural hematomas often occur near a region of the skull known as the terion. This is a place where 4 different skull bones meet: the frontal bone, parietal bone, the temporal bone, and the sphenoid bone. And this region overlies the middle meningeal artery. So fractures of the terion commonly rupture the middle meningeal artery, and that's what leads to an epidural hematoma. And if you look at this CT scan on the slide here, this is another epidural hematoma right here. You can see it's got the biconvex shape, but also you can notice that the skull is fractured right here. And so you commonly see skull fractures coexisting with epidural hematomas, and the region of the skull that's most commonly injured is the terion. And then finally, you should be aware that the dura mater has these regions where it's firmly attached to the skull by fibrous tissue called suture lines. And so epidural hematomas can't cross those suture lines. So usually the epidural hematoma is confined to one side like this. And that's because although the bleeding can push the edges out like this in sort of these directions here, it can't completely cross to the other side of the brain. And that's because of these suture lines that don't allow the dura to separate from the skull, and therefore they contain the bleeding at those regions. So what are the clinical features or the symptoms of an epidural hematoma? Well, first of all, remember that this usually follows trauma, and after the trauma, patients often complain of a headache. But beyond this, the feared complication of an epidural hematoma is that it will raise the intracranial pressure and start to compress the brainstem. And when that happens, patients can develop drowsiness and loss of consciousness. Another sort of classic feature of an epidural hematoma after trauma is what's known as a lucid interval. So what this means is that initially, after the patient experiences head trauma, they have a loss of consciousness from a concussion, not from the epidural hematoma. And so this passes in a few minutes or so, and they regain consciousness, and they may even seem like they're okay, except that they have a headache. But then they will have a second loss of consciousness, and this one is a very ominous finding. This means they have an epidural bleed, and the intracranial pressure is going up, the brainstem is being compressed, and they're at risk of herniating, which, as we just discussed, is the cause of death. So this initial loss of consciousness followed by a regaining of consciousness and a second loss of consciousness, this is called a lucid interval, classic finding in someone who develops an epidural hematoma. Okay, moving on, our next form of intracranial bleeding is a subdural hematoma. This occurs when there's rupture of bridging veins, not arteries. This doesn't involve the arterial system like epidural bleeds. The blood in this situation is going to fill the space between the dura and the arachnoid matter. It's called a subdural hematoma because the bleeding is below the dura mater, and this is in contrast to epidural hematomas, which are above the dura mater. And because the damaged vascular structure here is a vein, which has lower blood pressure compared to arteries, the bleeding in subdural hematomas tends to be slower because of the low pressure veins, and so the symptoms aren't always as abrupt or severe as in epidural hematoma. And so this is a nice picture on this slide which contrasts epidural hematomas and subdural hematomas. So in epidural hematomas, you often have a skull fracture, the middle meningral artery is ruptured, and you get blood filling this epidural space, which is beneath the skull and above the dura mater. In a subdural hematoma, you have rupture of veins, and so you have blood filling this space here, which is beneath the dura mater and above the arachnoid space. So just like epidural hematomas, the most common cause of subdural hematomas is trauma, and this can sometimes present acutely after trauma if a patient has a large acute subdural hematoma. So this can present similarly to an epidural hematoma with headache and loss of consciousness and signs of increased intracranial pressure. However, this type of bleeding can also occur chronically, so it can present weeks or days after an injury as a headache or confusion. That's because of the slow nature of the bleed. Initially, patients can have head trauma, they can think they're okay, the headache can be mild, and they go about their business. But days or weeks later, they present with signs of a large subdural hematoma. On CT scan, the blood in a subdural hematoma looks very different from the blood in an epidural hematoma. The bleeding in subdural hematomas is described as crescent-shaped, and basically what's happening is the blood is following the contours of the dura mater, because remember, the blood is just beneath the dura mater. And so if you look at the CT scan on the slide, this depicts a subdural hematoma. This is the bleed right here. It's described as crescent-shaped. Notice that it looks very different from the bulging outward bleed that we saw with epidural hematomas. And then also in contrast to epidural hematomas, subdural hematomas can cross suture lines. Remember, the suture lines are where the dura mater is firmly attached to the skull, and so epidural blood cannot pass those regions. That's different in subdural hematomas. The bleeding is beneath the dura mater, so it's not affected by where the dura mater is attached to the skull. The main anatomic limitation to the blood in subdural hematomas are the so-called dural reflections. There are certain regions in the brain where the dura mater folds inwards, and these are regions that subdural hematomas cannot go across. So, for example, the falx cerebri is one of these dural reflections. This separates the left and right hemispheres of the brain. The tentorium is another dural reflection. It separates the occipital lobe from the cerebellum. And so these are the regions of the brain where the blood in a subdural hematoma cannot cross. The major risk factor for subdural hematoma is older age. So as we age, there's some atrophy of the brain, and this increases the space that those bridging veins must cross inside the skull. This makes them more vulnerable to rupture. So fall in an older person who hits their head, this is the classic scenario for subdural hematoma. Other risk factors are alcohol use. People who use alcohol are more likely to develop one of these hematomas. And a lot of this increased risk is because of the risk of falling under the influence of alcohol. And then finally, blood thinners are also a major risk, especially because many elderly patients take blood thinners for atrial fibrillation, drugs like warfarin and apixaban, and this makes it easier for them to bleed if they have a fall and damage one of their bridging veins. You should also know that there's a second sort of special group that develops subdural hematomas, and that's babies who are victims of child abuse. There's a condition called shaken baby syndrome, which I talk about in other videos. One of the hallmarks of this condition is multiple subdural hematomas in a baby, along with retinal hemorrhages. Okay, now let's talk about our next type of intracranial bleeding, and that is subarachnoid hemorrhage. This refers to bleeding between the arachnoid and the pia mater layers of the meninges. So basically what we're doing in this video is going downward through the meninges. The most superior bleed is an epidural hematoma that's above the dura mater. One layer down, you get subdural hematomas that's beneath the dura mater. And if you go another layer down between the arachnoid and pia mater, that's where you get subarachnoid hemorrhages. And they're called subarachnoid because they occur beneath the arachnoid layer. This region where the bleeding occurs is called the subarachnoid space. And you should know that this is the region of the brain that contains cerebrospinal fluid. That'll be important later when we talk about diagnosis, because in this form of intracranial bleeding, you can find blood in the CSF. Also in this region, that's where you find cerebral arteries and veins, especially the arteries of the circle of Willis. And so as we'll discuss in just a minute, aneurysms of the circle of Willis can rupture, and that often leads to a subarachnoid hemorrhage. And that's because those blood vessels are running in this subarachnoid space. On CT scan, these types of intracranial bleeds look entirely different from epidural and subdural hematomas. You don't see any bleeding along the edge of the skull. Instead, what you see is blood filling the cisterns and fissures. So the basal cisterns are widened subarachnoid spaces at the base of the brain, and the fissures are grooves that separate the brain lobes, like the Sylvian fissure is a classic one. And so if you look at the CT scan on the slide here, this is a pretty classic image of a subarachnoid hemorrhage, and you should be able to identify this before your step exam. So all this white material is blood filling the basal cisterns, and it's filling these fissures out here. You can sort of see it coming out in these directions. Very different from those blood collections against the skull bones that we saw in epidural and subdural hematomas. So I mentioned this already, but the usual cause of subarachnoid hemorrhage is a ruptured berry aneurysm. I talk about berry aneurysms in detail in other videos, but these are aneurysms of large blood vessels that are part of the circle of Willis. One of those aneurysms develops, and the wall gets thin and it ruptures. That's going to allow blood to enter the subarachnoid space. Less commonly, you can see a subarachnoid hemorrhage from a cause other than a ruptured berry aneurysm. One of these is an arteriovenous malformation, or an AVM. This is a congenital deformity of blood vessels where you get a collection of arteries and veins without capillaries forming inside the skull. These are often found in the subarachnoid space, and so if one of them ruptures, that can lead to a subarachnoid hemorrhage. You can also sometimes see subarachnoid hemorrhage from trauma. You can see it in patients who have vasculitis involving the cerebral blood vessels. And then you can sometimes see this in patients who have endocarditis or bacteremia. The bacteria can spread to the brain and cause an aneurysm, and that aneurysm can rupture. This is basically similar to a berry aneurysm rupturing, except the cause is not a berry aneurysm. The cause is infection of vasculature inside the skull. So the clinical features of subarachnoid hemorrhage I talk about in detail in the video on intracranial aneurysms, but I'll briefly review them here. So the symptoms usually have a sudden onset when the aneurysm ruptures. Patients will complain of a headache, and classically they will say it's the worst headache of their life. They can have fever from inflammation of the meninges. They can also have nuchal rigidity, which presents with symptoms like neck stiffness. Usually the CT scan is diagnostic, although it's best early on and it's less accurate later on. And if you're highly suspicious of a subarachnoid hemorrhage, but the CT is non-diagnostic, you can do a lumbar puncture and obtain a sample of CSF. What you will see is xanthrochromia. This refers to a yellow color to the CSF fluid. That's what's shown here in this picture. CSF should be clear like this, but if it looks yellow like that, that's xanthrochromia, and that's what you can see in patients who have a subarachnoid hemorrhage from blood entering the CSF. And usually there are no focal deficits. The main clinical feature is headache. Usually you don't see things like focal weakness or sensory loss. Okay, our next type of intracranial bleeding is hemorrhagic stroke, also known as an intraparenchymal bleed. In this situation, we're talking about blood within the brain tissue itself. So we're beneath all three layers of the meninges. We're talking about bleeding that is beneath the pia mater and inside the brain tissue itself. This is a picture of what it looks like by CT scan here. Blood appears as bright white, and you can see blood is collected in a small region here within the brain tissue itself. That's an intraparenchymal bleed or hemorrhagic stroke. These strokes present with acute onset of neurologic deficits, just like ischemic strokes. The specific deficits you see vary depending upon the site of the bleed, just like they do with ischemic strokes. Beyond focal neurologic deficits, you can also see signs of increased intracranial pressure if the bleeding is large and it raises the pressure inside the skull. The usual cause of hemorrhagic strokes is blood loss from small penetrating arteries that are branches of major vessels. So these strokes usually don't involve bleeding from things like the middle cerebral artery or the anterior cerebral artery or the large vessels of the circle of Willis. Instead, they involve bleeding from small branches of those large vessels. The classic vessel to cause one of these hemorrhagic strokes is one of the lenticulostriate arteries. These are very small branches of the MCA, and they supply the basal ganglia and the internal capsule. That's this region deep inside the brain tissue where this bleed on this CT scan is shown on the slide. Hemorrhagic strokes are very strongly associated with hypertension. These strokes usually occur in patients who have longstanding hypertension, especially if it's been poorly controlled with medication. Some other associations I've shown in the slide. So any patient who takes anticoagulation for any reason is at greater risk of a hemorrhagic stroke. Hemorrhagic strokes can occur in patients who have central nervous system malignancies. The brain tumor can disrupt the small penetrating artery blood flow, and that can lead to a bleed. Hemorrhagic strokes are also a feared complication of ischemic strokes treated by reperfusion. So in another video, I talk about how we often treat ischemic strokes with lytic type drugs. These drugs are powerful clot busters and they can restore blood flow in cases of ischemic stroke, but the feared complication is that they will convert that ischemic stroke into a hemorrhagic stroke by causing bleeding. And then finally, there's a condition called cerebral amyloid angiopathy that commonly leads to hemorrhagic stroke. So let's talk about that now. So patients who develop cerebral amyloid angiopathy develop recurrent hemorrhagic strokes. And the reason this happens to them is because beta amyloid protein structures deposit in the walls of small arteries, and this makes them weak and prone to rupture. So beta amyloid is a collection of proteins. I talk about it a lot in other videos. It can accumulate in amyloidosis. It also accumulates in the brain in Alzheimer's disease, but sometimes it accumulates in the walls of small arteries. And when that happens, that can lead to recurrent hemorrhagic strokes. The bleeding that occurs in cerebral amyloid angiopathy usually involves the lobes of the brain. So, for example, the frontal lobe or the parietal lobe or the occipital lobe. Patients with this condition will have small strokes with blood on imaging inside the lobes of the brain. And this is different from the usual type of hemorrhagic stroke you see in hypertensive patients. Those types of strokes usually involve the basal ganglia and the internal capsule. These strokes in cerebral amyloid angiopathy are in different anatomic locations, usually inside the lobes of the brain. So the key clinical scenario to recognize this condition is going to be an elderly person because usually amyloid accumulation occurs among the elderly, and they will have recurrent hemorrhagic strokes, probably involving the lobes of the brain. And this is a picture here of brain tissue with beta amyloid deposition in an arterial wall. I don't think they're going to expect you to recognize this in your board exams. I'm just showing it to you so you've seen it once. Okay, so back to talking about hemorrhagic strokes. So the most common location for typical hypertensive hemorrhagic strokes is the basal ganglia. This is where about half of these strokes occur. Usually the strokes affect the internal capsule and the putamen, and the internal capsule is the most important anatomy to remember about these strokes. It runs between the basal ganglia structures, and it contains motor and sensory fibers that supply the face and the arms and the legs. So when you have damage to the basal ganglia from a hemorrhagic stroke, often the patient will present with hemiparesis and hemisensory loss, and that's because of damage to the internal capsule. You can also see gaze deviation toward the side of the bleed. This is because the basal ganglia lies very close to the frontal eye fields in the frontal lobe, and when they get damaged, you get gaze deviation toward the side of the bleed. And then the diagnosis is usually made by CT scan, which will show blood. And that's what you see on this CT scan here. This is blood in a deep structure. That's where the basal ganglia and the internal capsule run, not out here in the lobes of the brain. Usually these are deeper structures down here, classic for hemorrhagic stroke involving small penetrating arteries of the middle cerebral artery. And then beyond the basal ganglia, you can also see these hemorrhagic strokes in these locations here. You can see them in the cerebellum and the pons. These will lead to brainstem symptoms. You can also sometimes see them in the lobes of the brain, especially in cerebral amyloid angiopathy, like we talked about in the last slide. Here's a slide showing the basal ganglia, which I go over in detail in our video on the basal ganglia itself. But I just want to remind you that the basal ganglia are these 5 structures here, and they're all so-called deep structures. So you find them sort of in the middle of the brain, not out here in the lobes. And since the basal ganglia is where most hemorrhagic strokes occur, we often say hemorrhagic strokes affect so-called deep structures, and that's what we mean. Also notice that the internal capsule, which is right here, runs right through the basal ganglia on both sides. And so that's why when you get strokes that damage the basal ganglia, often the internal capsule is damaged. And that's important clinically because that's going to lead to hemiparesis and hemisensory loss, which is one of the major features you can detect on physical exam. The underlying cause of most hypertensive hemorrhagic strokes is so-called Charcot-Bouchard aneurysms, which I talk about in more detail in the video on intracranial aneurysms. But these are microaneurysms, and they're called micro because they're not visible on imaging. You can only see them on path examination of brain tissue. They're strongly associated with hypertension, and they're common in the lenticulostriate arteries, which, as we just discussed, are these small penetrating arteries of the MCA. And these arteries supply the basal ganglia and the internal capsule. And so when a person has hypertension, they develop one of these Charcot-Bouchard microaneurysms. And if it ruptures, that leads to the intraparenchymal hemorrhage of a hemorrhagic stroke. Okay, and then our final form of intracranial bleeding is an intraventricular hemorrhage. This is a form of intracranial bleeding that occurs as a complication of premature birth. So this is something you're going to see in premature babies. It's called intraventricular hemorrhage because it involves hemorrhage or bleeding into the lateral ventricles of the brain. Usually this develops in the first 5 days of life. It presents with loss of consciousness and hypotonia and loss of spontaneous movements in the baby. If the bleed is very large, it can also cause seizures and coma. The blood is usually easy to visualize with ultrasound, and what you will see is blood inside the ventricles. And so if you look at these images on the slide, these are all ultrasound images of premature babies. In this one in the top left, these are the two ventricles here, and this represents a collection of blood inside each of the ventricles. Over here on the right, we've got another image in one of the lateral ventricles. This is blood that's collected here. Down at the bottom, another ultrasound image in a baby of the ventricles, and this is another collection of blood that you can see. The reason that premature babies are vulnerable to this type of intracranial bleeding is because of problems related to the germinal matrix. So the germinal matrix is a highly vascular area that's found right near the lateral ventricles, and it has reduced glial fiber support. So what do I mean by this? So glial cells in the brain produce fibers that support blood vessels, but there's less of that for these blood vessels in the germinal matrix right near the ventricles. So as a result, the capillaries are very thin-walled. Now, this area of the brain usually involutes by about 32 weeks, but in premature infants, it can still be present. In a full-term baby, it would have completely involuted and gone, but it's still present in babies born very prematurely, especially before 32 weeks. And this region of the brain has very poor autoregulation. It's got friable vessel walls, and so it's very prone to rupture and bleeding. And when that happens, the blood is going to flow into the lateral ventricles. One of the complications of this type of bleeding in a premature baby is non-communicating hydrocephalus. So let's take a look at this drawing on the slide here. These are the lateral ventricles where blood is going to enter in a baby who has intraventricular hemorrhage. Those ventricles drain into this small area here called the interventricular foramen, also known as the foramen of Monro, and it can get filled with blood cells and clot and become obstructed. And when that happens, that is a form of non-communicating hydrocephalus, which I talk about in detail in other videos. But basically, you're going to have increased CSF above the obstruction in the lateral ventricles and decreased CSF in the ventricles below the obstruction. And this can be visualized by ultrasound imaging of a premature baby's brain. You'll see enlargement of the lateral ventricles, but a normal third and fourth ventricle because those are not affected. And the clinical problem this presents is that the intracranial pressure goes up. So in a premature baby, you can see bulging of the fontanelles. Another classic finding is called sunsetting eyes. This is when the irises become displaced downward on exam. This is another finding of raised intracranial pressure in a newborn baby. And then eventually the baby can develop apnea because of compression of the brainstem. One of the treatments for this condition is a ventriculoperitoneal shunt. It's a surgically placed shunt that drains CSF from the ventricles down into the peritoneum and the abdomen. It will lower the pressure in the brain and relieve the increased ICP. And so now we've discussed all 5 different forms of intracranial bleeding. The best way to reinforce these concepts is to go and do our questions right now. We have questions associated with this video on all 5 of these different types of bleeds. And once you do those, you will really get down how to recognize them and how to identify the underlying pathology. And that concludes our video on intracranial bleeding.